to talk about you.
Okay. Well, I'll just introduce myself again. I'm David Hafler. I'm chairman of the Department of Neurology at the Yale School of Medicine, and I am an immunologist. I'm in the immunobiology department. I had spent my career at Harvard Medical School for 28 years, and then 5 years ago was recruited to Yale. As they say, there is life after Harvard. It's a wonderful place. Though I'm still an emeritus and at Harvard, and you're supposed to say, but you look too young. And thank you. Thank you. Yeah, anyway. And again, spent my life studying this disease.
How's it going? I'm Jack Osbourne. I am not a doctor, and I'm probably the least qualified to be discussing MS on this panel. But nonetheless, I know what I know. I just want to thank Nancy for once again inviting me on the panel, and yeah, that's about it. And also thank the doctors.
Yeah, Jack, having MS, he doesn't know anything about it, of course. So listening to patients is key, and so thank you for being here. I just wanted to say I'm not Peter Calabrese. Peter Calabrese is the head of the MS Center at Johns Hopkins. I'm privileged to be able to work with him because he, like Nancy, understands that there are things that happen above the neck, not just below the neck with MS. Peter is doing what is, I think everybody would agree, one of the hardest jobs there is, which is his wife is sick, so he's taking care of his wife and 3 kids at home right now. Otherwise, he'd be here, but sorry he couldn't make it, and I'm trying to stand in and fill in for the psychiatric aspects of MS. So thanks.
My name is Dan Pelletier. I'm a neurologist. I'm a professor of neurology and diagnostic radiology at Yale University. I'm the head of the MS division and neuroimmunology division at Yale. My interest in research is about imaging. So we're going to be talking a little bit about repair and then regeneration. So I'll have a few comments.
I'm Dennis Bordette. I'm chairman of the Department of Neurology at Oregon Health and Sciences University, which is in Portlandia, not the football team in Eugene. My 2 major areas of interest with regards to MS research is developing therapies for progressive MS. And then we also have a keen interest in the role of diet, exercise, and wellness approaches in managing MS.
I'm Emanuel Boba, and I'm a professor of neurology and pediatrics at UCSF in San Francisco. I have the privilege also to be the medical director for the group here, the Center Without Walls, which has been really terrific to work with Nancy to advance research about MS. And we're working hard to try to find a cure. And I know Nancy wanted us to find a cure yesterday, but we're still working on that. My personal interest in terms of the research in MS are 2 main things. The first one is to design clinical trials that will help understand whether medications are helpful to slow down progression of MS. And I'm also interested in understanding risk factors for MS. So what are the risks in the environment that in combination with genetic risk factors can make that one person will develop MS, whether another one won't. And also what are these risk factors in the environment that modify disease progression, because some of them we can address, like vitamin D, for example. So a little different than being the director of the center, but equally as exciting. I'm very glad to be here today with you. Thank you.
Thank you, everyone. I'm Claudia Curry-Hill. I'm the moderator at the panel, and I also have MS for about 30 years now. And like I said earlier, there was nothing then, but now there's so much to be excited about. So I'd like to go on and let's talk about our next topic, which is regeneration and repair. Dr. Danielle Pelletier and Dr. Leslie Wyner, please comment.
Age before beauty. Well, I think that there are now, I think, about a half a dozen agents that are in the pipeline that in experimental models, which are very critical in development of therapies, seem to prevent the degeneration of axons and neurons. Now, if you prevent them, the body still has the means, even if you're in your 60s and 70s, to repair things. But you must be able to stop the process in order to do that. It's of great interest, I think, right now, to look at the factors that we think are producing the degeneration, because there is the first phase of this disease, which is the inflammatory phase, and then as time goes on, you went into the secondary progressive phase in some patients, and I think that that group of patients, the anti-inflammatories don't seem to make any headway. So we need to get around the fact that once you cut an axon, it's not going to repair. So there's still the fundamental idea is to prevent that. But we are looking at a variety of things. The stem cell field, although it is interesting, we're a little skeptical. I'm skeptical. I shouldn't say we. I'm skeptical that these cells actually get into the nervous system because they're all basically put into the blood. And whether they get into the nervous system and then can produce a repair. They are immunosuppressive, but we have cheaper and less dangerous ways to immunosuppress people. But quite clearly, the future of stem cells are just being recognized. There are probably about 50 clinical trials worldwide looking at a variety of stem cell treatments. And I think that the interesting aspect has been a field in which we take a piece of skin, treat it in a certain way, and we can make embryonic stem cells that are unique for that patient and are unique for their disease. So that is a field that's quite exploding. It provided for a Nobel Prize 2 or 3 years ago for the person who developed it. And a lot of the work that's being done on MS is actually being done on the cells that have come from an MS patient and have now been developed into neurons and cells that make myelin, et cetera, et cetera. I think that the regeneration field is just taking off. We will certainly have some agents that are being tested. There are some newer drugs that are first going into clinical trial now and will be tested in secondary progressive patients to see if we can do something about repairing them and stopping that degenerative phase. I think it's an exciting time, and I think the more we know about the generation of this process, the easier it will be for us to change it, but it is a difficult point. We do know that if you look at some studies that were done in the Mayo Clinic before we ever had any treatment. Now, I don't think that the middle of Minnesota is typical of the United States, although they think it is. I think that they had some valuable data. In the 1980s, if you developed MS, the process would have meant that 75% of you within 5 or 10 years would be in a wheelchair. Now, today, that figure is reversed, and it isn't 5 to 10 years, it's 10 to 15 years. So there's been tremendous progress, and it is all based on anti-inflammatory agents. So we are now able to focus on some of the aspects that those anti-inflammatory agents don't do, and that is to look for things and ways to get regeneration. I would remind you that the major cause of degeneration is the destruction of myelin. And I think that that's a process which, if you can prevent, you will have half the battle won. So with that, I will ask Dan Pelletier to tell you what else about degeneration.
Well, thank you. The reason I wanted Dr. Wyner to talk before me was not because of age and beauty. It's because Dr. Wyner knows what to do. What I wanted to talk about is the importance of developing tools and metrics to measure repair and regeneration. Dr. Boba was talking about new drugs that we have in the pipeline to test for myelin repair and regeneration. We probably have many, many options. We probably have perhaps too many options for the number of clinical trials we can put together. So one strategy, I think, which is essential, is to develop tools that can lead the way and decide which one of the hundreds of molecules we would like to test, but only test the best ones, the ones that have the best chance at moving forward. So, and that's the part of my research, and the imaging field in MS has been tremendously successful. I think in MS, compared to other neurological diseases, we have been very successful at developing tools to see the disease, to monitor the disease. We've been successful at treating the inflammation part of the disease, predominantly because we've been able to see some of the inflammation with the imaging. But now we need to move forward. We need to build on this success, and we need to be able to measure myelin repair. We need to measure what's going on in the gray matter. And part of what we do is we develop these tools. We have the ability now to image MS at a very high resolution. We're very fortunate in the field of research to be able to have these tools and to see the disease in ways we've never seen before. We have the ability to also measure metabolites, chemicals, small, tiny proteins. And actually, that's helpful. That's quite helpful. And then the field of myelin repair regeneration will definitely benefit from these tools. And I just want to say that in MS, again, we're leading the way in terms of developing these metrics to monitor.
He's French, you know.
Well, that's nothing to do with that. That's nothing to do with that. But I just wanted to comment and finish on the, again, we have the ability to see things that we weren't seeing 5-10 years ago. And MS and the imaging field in MS is really leading the way in terms of measuring progression.
I want to just make one brief point just about promising therapies. We've talked about medications, but a very common question is, well, if you're diagnosed with the disease, what can you do to change your life habits? I mean, medications work, and really everyone who has clear MS with lesions developing should be on medication. That being said, and I can't believe I'm saying this, but it's LA, but I really think diet matters. We know that, and it's not, and we're beginning to learn this. So we know that high-fat diets, we know high-salt diets, driven under the golden arches, induce inflammation. And one of the projects that's being funded by the Race to Race MS is a trial that Dr. Pelletier is running with us to lower salt in a very defined clinical environment. We showed that salt induces inflammation, a major inducer of inflammation, and induces much worse in the animal model of multiple sclerosis. We know that high fat induces inflammation. We know that smoking induces inflammation. And we know lack of vitamin D. A lot of work that Emanuel and others have done is probably important. So again, 5 years ago, I would have been shaking my head, but I do think there are things we can do in our environment to perhaps cut down on inflammation. And it's not just about drugs.
You have come a long way.
Not too much.
Thank you, Dr. Heffler. Now, just a moment.
I'd like Dr. Bourda to comment on a diet study he just completed about the high-fat diet, I believe. Maybe Dennis, you can comment on that?
So something must have happened to you, David, when you left Boston.
Fresh air.
Fresh air, yeah. We just reported on a trial of a vegan diet that was completed, which is a low-fat diet. And it was a one-year study, randomized study comparing 25 people on the diet versus 25 people who remained on their usual diet. And the trial showed dramatic effects on quality of life and on fatigue in those that followed the diet. So I think investigation of dietary approaches are important for the field and for everybody who are affected by the illness.
All right, now Kurt's out there gathering questions, so if anybody has any questions for the doctors or any of the other panelists, please hand them forward, and Dr. Wyner and Dr. Hafler and Dr. Boba will help direct who should answer them.
And I have already a couple of questions here somehow that ended up on my lap, so maybe I'll start with that while you're dispatching the questions up front. One of the questions is, what are the new advances in secondary progressive MS? And you have already heard a little bit that there are trials right now trying to evaluate medications or strategies to actually help repair, and that has to do with remyelination, but also with neuroprotection. There are several trials ongoing right now. I would cite only one that is NIH-sponsored that has started a few months ago with a medication called Ibudilas that is happening at more than 25 centers in the US that will look at the effectiveness of the medication to slow down progression in patients with progressive MS. There's also, in addition to testing drugs that are FDA approved for preventing relapses, and now we're testing whether they also slow down progression of the disease, there's a lot of efforts that are being done in terms of designing better trials. Because as Dr. Pelletier has alluded to, for many years we have been quite comfortable looking at a very specific marker on the MRI, that is the development of new lesions. But if you're looking at preventing progression of the disease and even repairing, we totally have to shift in terms of how we're thinking of what we should measure. And there's an understanding now that the design of the study should also address that, not only the metrics we're choosing, but also how the studies are designed. I'll stop here because now there's plenty of questions in front of everybody.
So who's ready to start answering questions? Les?
Yeah. I have a question here about cord blood. We do recommend that cord blood be saved. I have an unfortunate experience that one of my children, I told him it wasn't important when he had his first child, but I told him afterwards it was. And he never forgave me for the fact that 2 of his 4 children don't have cord blood saved. Now, for the person, the mother or the father, you realize, and as I remind my wife, that cord blood has more has some father in it. It's not just the mother. So for the person who is the mother, the cord blood is not very useful. But for the child, when that child grows up and when the child has other problems, the cord blood can be used, and we do recommend that it be saved.
Dr. Wyner, can that saved cord blood help the parents?
It doesn't help the parents.
It does, only the
No, no. I mean, any more than a stranger might, because the issues related to the cord blood is that there is fetal blood in there, and the fetus is not just you. Right? I think that that's okay as well. Society doesn't have a problem with that.
So this is a very common question. I would just say there are wonderful questions here. Since I have MS and my children susceptible, so we started by saying that MS, that we've identified the genes that cause MS. So what does that mean to one's child? If you are of European ancestry, then you have an increased risk of developing MS. The frequency is about 1 in 1,000. Indeed, if a parent has the disease, there's a slight but real increase in the risk to the child, but it's still extremely low. So it is inheritable, but the odds the child having the disease are still reasonably low, probably about 1 in 100 or so. Try winning a lottery on those odds. So again, there's a genetic component. If you have identical twins, the odds of the other twin having the disease is about 30%. It doesn't mean it's 70% environmental. It probably relates to the number of genes, or the gene load. If there are 250 genes that are involved, if you have all of them, you may have 100% risk. So it probably relates to that factor.
I do have a question here ready with many good questions. One is, what are the tools to measure progression? So that's a key question for patients and for clinicians. Typically, we monitor progression based on a neurological exam. Doctor may ask you to walk, and your doctor may ask you how far can you walk and how strong you are. And at times, we may have to actually use a neurocognitive testing. That's also important. What I do say, though, what I do in my clinic is we also use imaging to monitor progression. So because sometimes we don't want to wait till patients have progressive features of MS, but we can use imaging, and then we, on a regular basis, we can image patients. And what does that mean exactly? So essentially, when patients are not having acute attacks, we do image on an annual basis. And there are differences of opinion on this topic, but this is a consensus that we have, at least at our center. We do image the brain and the spinal cord every year, and we monitor plaques, we monitor new lesions, and that could give an indication whether or not the disease is actually ongoing and progressive. So imaging is also a tool in addition to a standardized neuro exam. And the images are conventional images. Essentially, your doctor may ask